just record you for the introduction?
Yeah, okay. I don't know. I guess maybe I'll stand close enough to you, but okay.
Okay. I want to step off just to give them a handout. You can go ahead and get started.
Okay. Welcome, everybody. This is the second breakout session, and I'm the moderator for the session. My name is Megan Herder. I'm a law student here, and I am pleased to announce Dr. Shirley Blanchard. She is going to be presenting. Her speech is called Visual Perception, Dysfunction, and Parkinson's Disease, Interprofessional Approach. And she is an associate professor in the Department of Occupational Therapy, fellow of the American Occupational Therapy Association, and fellow Health Disparities Research. She has taught courses related to neurological dysfunction and intervention for the orthopedic patient. Her research includes health disparities that focus on the self-management of obesity and cardiovascular risks among women or minority women, and the use of we as intervention for Parkinson's disease. So, let me introduce her.
Okay. Since we have kind of lost 5 minutes, I will try and speed it up a little bit, but not talk too fast. Thus, the handout. And what I plan to do today is just look at a little bit of the common visual deficits that we see in Parkinson's disease. There's not a lot of research, but there's going to be more research on why we need to look at visual perceptual dysfunction in Parkinson's. And then we're going to look at some visual strategies that occupational therapists use in conjunction with neuro-ophthalmologists as well as neuro-optometrists. And then we will look at some interdisciplinary assessments that we can use. And if you have family members that have Parkinson's disease, you can take your handout back and say, these are some things that I learned. What do you think about this? Okay? So I know I don't have to explain Parkinson's disease to most people in this room. Everybody knows that it's caused because of depletion of the pigmented cells in the substantia nigra. Typically, dopamine is a neurotransmitter. We know that. And typically, it interferes with the function of the striatum, which is the caudate nucleus, and the putamen. I had tons of neuro slides in, and I took most of them out. And I'm going to focus on one slide that's going to summarize everything for you. We know that dopamine is accompanied by or balanced by acetylcholine. And this is another neurotransmitter in the central nervous system and the peripheral nervous system that allows us to be excited. It can be excitatory or inhibitory. It balances those two things. It also balances our level of arousal and attention. Unfortunately, a lot of our clients with Parkinson's disease will lose 70 to 80% of their dopamine before they start to see these signs and symptoms. And so by that time, they know something is wrong, but it's quite a ways down the road. Okay, so that's my one favorite, absolute favorite picture. Now, it looks like a whole bunch of stuff going on here, and it really is, but I plan to summarize it in terms of the basal ganglia and the structures in the basal ganglia and how they contribute to vision dysfunction. Let's talk about RF, which is actually the reticular formation, and that's responsible for swallowing, movement of the tongue, and here we go, eye movement already, and then fatigue. We have our corticospinal pathways, which are actually responsible for voluntary movement of the trunk and the limb. So here's our corticospinal pathways that run this way. Okay, I'm going to make a big point here in just a second. Corticobulbar pathways, if you look at corticobulbar, they're here. They are also responsible for movement of the face, the head, and the neck. The face, the head, and the neck, the eye drives motor control or motor movement. And so with clients with Parkinson's, they tend to lose that. So, and I ask the students this all the time, so what if we get that sensory stimulus, and you learn that that sensory stimulus goes to the motor cortex or the cerebral cortex, it comes back down in a motor response. What if that's not true? And Novak, back in 1996, did some research and said it's not straight up and it's not straight down. It takes a turn, some wicked turns, he calls them. Okay? So, number one, that sensory stimulus may go to the cerebral cortex, but it's going to jump around to number two, the putamen. Okay? And here's our frontal eye field. Clients with Parkinson's have to realize that they're looking at something first. And there's some things that get in the way of them being able to process visual information. And that has to do with dopamine. They need to be able to shift their attention, which a lot of clients with Parkinson's, once they get to stage 3 or stage 4 or stage 5, cannot do that. And then do they remember their motor patterns? They may have problems with memory as well. So it goes from number 2, then it swings all the way around here to number 3, the caudate nucleus. Can a client with Parkinson's recognize, have voluntary movement, but recognize the things that are in spatial relations, things that are around them? So this may set them up to fall. Okay? So here's number 4. It jumps back around to 4 to the globus pallidus, the facial muscles, postural stability, and their ability to select a motor response. Well, a lot of things happen at number 4. Number 4 is also, all of this is basal ganglia, but number 4 is also where we pick up dopamine in the substantia nigra. And if we don't have dopamine to get picked up, then guess what? It doesn't go over to ventral anterior or ventral lateral or get processed in the thalamus to allow that sensory response to get what? To allow the sensory to get processed as a motor response. So we get stuck in 4 and we don't have a motor response, or we have a delayed motor response, and we need dopamine to carry it all the way to the motor cortex. So just ways to think about it, okay, how it's all intertwined. Vision and head movement is needed for motor control and postural control. Okay. If you look at the epidemiology, we know that the Parkinson's Disease Foundation, this is really interesting, I thought. Parkinson's Disease Foundation says there are about 10 million people in the world living with Parkinson's disease, although WHO says there are about 5.2. So depending on what website you go to and look at the statistics, it's a little bit different. I thought it was interesting as well that low vision in the world makes up 272 million people. Of these people with low vision in the world, Parkinson's is not in that group. However, glaucoma with peripheral vision loss and macular degeneration with central vision loss is leading the way. And my goal is to begin to look at how much of that group is actually clients with Parkinson's disease rather than age-related or race-related glaucoma. Okay. So what we know is, and the research is saying, that dopamine impacts the neurons or the pigmented cells in the eye, which is in the retina. Okay? The retina actually transmits those electrical signals to the brain. And for people with Parkinson's, because they have insufficient dopamine, they have an altered vision response. So their perceptual, what they're seeing in the environment may not be what you're seeing in the environment. This is a good schematic for that, okay? Light falls on the pupil, or it comes in through the macula, and then it's transmitted to the retina. Once that light hits the retina or the aquamarine cells, then we start to see a color disbursement. Clients with Parkinson's don't have that same color disbursement, okay? So as I think about these people, Hunt calls it blue-yellow color blindness is what they start to see. But actually it's contrast sensitivity. They lose that ability. And this is a good example of that. Like us, if the object falls on the fovea or the macula, they should be able to see it. Well, Parkinson's clients are able to see something, but it gets diminished. Those special features that bring it onto the retina, their ability to see the color clear and sharp starts to diminish with less dopamine. And so as we look at that, and I'm an OT, it's like, why is an OT looking at this because everything in our environment has color, every facial expression. Clients communicate, you know, what they see from your facial expression, and sometimes they may misread this because they can't see it clearly anymore, or even make out what it is. And we'll talk about this a little bit more. So, because they have this reduced dopamine, they're going to have problems with what? You can look at the whole list up there. Okay, they'll have problems with spatial deficits. They think they're going to sit on the chair, but they're not sure it's the chair, and they sit on the floor. Okay, and your head is going up and down.
This is I won't interrupt you, but this is almost some perfect descriptions of what's going on with my mom.
So
almost
yeah,
perfect.
Yeah, you can give examples. I know. I think about it all the time. Okay, because, and I'm going to jump way down to number 3 here for a second. Our musculoskeletal muscles are typically striated, which means that we can strengthen those muscles. But the muscles in the eye are striated, and because those muscles in the eye are striated, they're going to have the same symptoms with Parkinson's. The rigidity, the slowness of movement, akinesia will also be seen in eye muscles. Okay? There are 2 types of assessments that occupational therapists, we call them confrontational tests, similarly to ophthalmologists and optometrists. And those are saccades and pursuits. Saccades are those fast eye movements that when you're reading, you're watching a tennis match on the TV, and you can adjust your posture, your balance, and your motor response based on head position and how fast the eye movement is. You pull up to a stop sign, something you think you're going to stop at the stop sign or a yellow light, and you hit the brakes, that kind of thing. You get that feedback and you respond immediately. Smooth pursuits, then, is following a moving object. Okay, we follow moving objects all the time in our environment. Okay, so we have saccade movement and we have smooth pursuit. Clients with Parkinson's disease, however, have a change in their pursuit and a change in their saccade. And typically, if we look at their 3 typical cranial nerves, number 3, 4, and 6, that move the eyes up or down or in and out, they have very slow movement or voluntary movement there. And this is where occupational therapists tend to work with the ophthalmologist or the neuro-optometrist, and we'll look at some of the assessments that they do versus what we do and how we share and use information. Research suggests that clients who don't have sufficient dopamine, especially clients with Parkinson's, have difficulty with superior vision field. And we're going to talk a little bit more about that. Because as their vision field changes, okay, it changes a lot because their center of gravity drops, they get kyphotic, and then they have the forward head posture. Okay? So be thinking, we'll come back to this later, that the center of eye movement is related to not only the midbrain, but the brain stem as well as the occipital lobe for processing information. The occupational therapist and the ophthalmologist are going to look at similar assessments. And we take our information from them. They go there first, we get the report, and then we start to work with the client. Okay? You'll notice that this says neuro-ophthalmology exam. You'll notice that Warren is an occupational therapist, and this is her research area. And she looks at vision dysfunction in neuro clients. It used to be just TBI, but now she's expanded that to the majority of neuro clients. The ophthalmologist is going to look at visual acuity. The OT is going to look at visual acuity. They're going to look at vision field. We're going to look at vision field. They're going to look at eye movement. We're going to look at eye movement. And we're going to look at all of these things as it relates to attention, being able to scan in the environment, pattern recognition, visual memory, and visual cognition. We're not covering these today. That would be 5 or 6 other things. So I'm just going to try and stay focused just on those 3 things, okay? So visual acuity in Parkinson's disease. A lot of clients with Parkinson's say they can't see. Blepharitis. Sometimes they have inflammation or chronic inflammation of the eyelids. That needs to get taken care of from the ophthalmologist or the optometrist before they see us. Okay? Sometimes their eyes will drift outward. That has to do with, okay, do they have disuse atrophy of the eye muscles? So we need to know how much are you using your eyes. They may have double vision because of that, diplopia, or abnormal vision processing, that contrast sensitivity that I talked about earlier. Okay? So sometimes they will have a droopy eyelid, a ptosis, okay? And our optometrists have come up with, these are called eyelid crutches, to help them hold their eye up. There's all kinds of things that they can do. Used to be a little hook for our clients with traumatic brain injuries. We have a little hook that we put on the eye that keeps the eyelid open. And then, of course, when they get ready to go to sleep, they don't have to use that. Okay? I'll keep going. Contrast sensitivity. There's decreased dopamine in the retinal structures. We talked about that. They have altered color perception, and it's linked to a decline in motor function. Now, I always thought that this was pretty interesting. I use the Snelling chart in the same way that ophthalmologists and optometrists do in terms of looking at most clients that I suspect may have a visual acuity issue. Clients with Parkinson's disease have contrast sensitivity. You won't pick that up on the Snelling chart because it's what? High contrast. So you need to go beyond that, looking at other things in the environment. They will have problems with their vision on dizzy, dim, or cloudy days. Okay. They'll have problems with applying makeup or facial features. We talked about that. They may have problems with driving, and that's why it's so important. Optometrists have filters, and they can help them find the right filter that gives them the contrast so that they can see what's in the environment. And then once they get the filter, they can come to OT, and we can work with them on that. Okay? Occupations such as cutting up a white chicken on a white cutting board, they're not able to see it. The OT is going to create these opportunities for high contrast in the environment. Okay. Other considerations then, sometimes they might have to have 2 pairs of glasses. I know some people have bifocals or trifocals, but sometimes because their eyes move slower and they don't have the movement, they can't make the adjustment quick enough, so they may need more than 1 pair of glasses. They may also need to have prisms. And prisms bring things into the vision field, and we'll talk about that more. In terms of dry eyes and inflammation, that's an ophthalmologist or optometrist intervention. I put this research study in. I thought this was really interesting from Lee, 2001. Suggests that dopamine concentration is higher in portions of the retina that supply the upper vision field. And these are the ones, but lower in clients with Parkinson's. So they have a restricted eye gaze, and once they start to try to lift their head, this is what gets them into trouble. They lift their head, and they're kyphotic, and it puts them into a fascination of gait, and then they fall. And so my challenge and my advocacy is, how do we get them services early enough that we prevent them from going into kyphosis and a downward position in the head? Once we get the downward position in the head, now we've set up other things like aspiration. Now they can't swallow. Now we have to work with speech pathology to find the best intervention for swallowing and or for speech. I said before that the midbrain, here's cranial nerves 3, 4, and 6, but there are multiple areas in the brain that have some contribution to vision. We're not going to get into all that today. Okay? This is just a picture of looking at pursuits and saccade, cranial nerves 3, cranial nerves 4, and cranial nerves number 6 on moving the eyes up, down, in, or out. And all of these may be involved in Parkinson's disease. Okay. I talked about the kyphosis. I talked about the upper vision field. The head leans back. They get a retropulsion of gait, and then their center of gravity changes, and they tend to have more falls in the environment. Our goal as practitioners, if it's OT and PT, is to prevent this so that the patient is safer in their environment. Okay. EMG studies demonstrate that bradykinesia is also seen in ocular muscles. The same slowness of movement that we see in the extremities, we see in the eyes. They may also have postural sway or increased postural sway. Clients with Parkinson's disease may be just standing and have much more postural sway than other people. Okay? We talked about saccades, and we talked about the slowness of the saccades. Okay. Convergence insufficiency and diplopia. I brought a pair of prisms. These are not actually the prisms that we would actually use in real life, but I wanted to make the point that because they have a problem being able to see and what's above them, actually these prism glasses are typically used for our clients with spinal cord injury, and it brings things that are lower up here so that they can see them. But I turned them around the opposite way because I wanted to bring those things that are higher down lower so that our clients with Parkinson's would be able to see. And so, no, I'm not going to give them these, but I'm going to work with the prisms. If I think that that's going to work for them, I'm going to work with the optometrist and the neuro-ophthalmologist to see which ones might work. And I have a quick video that we'll watch shortly. If they have double vision, typically occupational therapy is not going to make that. We suspect they may, but they'll say, I'm seeing two of everything. And we might say, well, maybe patching is good for you. And then we might call the ophthalmologist or optometrist and say, this is what they're describing. And they might say, well, go ahead and try this type of patching. Okay? And patching is going to suppress one eye to get the patient to use the other eye. And it's important to switch off so that you don't permanently suppress an eye so that they can't see. Okay? Vision is also connected to proprioception. And when we talk about proprioception, we're talking about, do you know where your body is in space? Can you actually get input and be able to move or come up with a motor plan? If you don't have proprioception, your balance is going to be off. You think, oh, I'm going to hold on to this wall here, or I'm going to hold on to the counter. And you miss the counter because your vision is off, can't feel exactly where you are. So we need to teach our patients to use their sensory input so that that can help drive their vision input. Put your hand down and look at where your hand is. Okay? Vision is also used to compensate for reduced proprioception. We need to make our clients aware of what their vision is. When I talk to clients who have Parkinson's disease at the med center, one of the things that I think is really interesting is that they have the lived experience of all this, and they'll raise their hand and say, I did that. I know what that feels like. I've fallen several times from doing that. And it's taking the information that they give and saying, now, let's go get you checked out, get you a full vision assessment from the ophthalmologist and see what's really going on with you. Back in 1967, Hone and Yar came up with a staging. Some of you know this, the staging system for Parkinson's disease. Okay? And we're going to briefly go through each one of these. That staging system looks at the level of motor involvement, and it looks at the level of functional impairment. In working with clients with Parkinson's at the Med Center, I found out that most of them were not aware of what Hone and Yar level or stage that they were. And they were like, can you tell me what I am? I said, no, but your neurologist can. You know, there are multiple things that go into that. What's interesting is visual perceptual changes are not included in Hone and Yar. What's interesting to me is the Unified Parkinson's Disease Rating Scale does not include vision perception, but they look at everything else that's neurological. And I'm like, they should talk to OTs. No. Well, and I'm like, well, why is that? So, are you guys medical students? Or do we have any medical students in here? Medical students? Oh, I was hoping we had a couple of medical students because I was going to ask them how many routinely looked at vision perception for, I was really going to put them on Okay. Okay, so here's Hoehn-Yahr stage 1. Hoehn-Yahr stage 1 is unilateral involvement. And these are our clients. We're not going to go through every one of these items on the slide, though. Typically, they start to have problems with the visual acuity. And they will say things like, I can't see when I read, when I go into a dimly lit room, it takes me a long time to find things. Okay? They may also have dry eyes. Okay? This person has unilateral neglect. If we have time, we'll watch the video on all of them so that you can see them. Okay? Our OT assessment then for Hoehn-Yahr stage 1 is we're going to be not only looking at the Unified Parkinson's Disease Rating Scale and what the neurologist found, but we're also going to look at the clinical signs and symptoms. We're going to look at the Snelling chart, and we're going to look at contrast sensitivity as well. We're going to do confrontational tests, and we don't have an SLO or scanning laser ophthalmoscope, but our ophthalmologist does, and the ophthalmologist also has the Humphrey. Most of you have taken that assessment. You sit there with a little button, yep, you press it when you see something in the peripheral. And that's what we want to do with clients who have Parkinson's disease. We want to see, did they have a visual field change, are their eyes moving, and is it going to show up? Here is just a visual field deficit for a client using the Humphrey. Of course, the Goldman is the standard assessment. This is what contrast sensitivity looks like. Most normal people should be able to read these, but as you go down, it gets lighter and lighter and lighter. Okay? And that's what we need to assess for clients with Parkinson's. We can also do confrontational tests. This is pursuits again. This is those slow movements, right and left, left and right. We can have them count down or up vertically. We can have them read the numbers across horizontally. Okay? Sometimes they may miss numbers. It depends on how, and you can build contrast sensitivity into this as well. Okay? Saccades, fast movements, we can ask them to read a series of numbers very quickly, or we can make it more what we OTs refer to as occupation-based and have them find things in their environment and point to them. Can you point to the refrigerator? Can you report? And what's driving that? Memory. They remember where it is. Or where's your shoe on the floor? Okay? Or can you point to these things in the environment? Okay? This is just a letter cancellation test that we can have them do. We can make it more occupational or more meaningful to them by asking them to cross out all the letters that start with the name of your street. So they really have to search hard for it. Okay? Other low vision strategies then, we can change the background color. Okay? Avoid patterns in print. Prevent glare and use a matte finish. Increase the illumination, put lighting behind the shoulder. And we need to think about using fluorescence, which combines all of the colors or most of the colors in the spectrum, rather than just a simple light bulb, which may just deal with blue light or yellow light. And the blue light, yellow light alone is what clients with Parkinson's disease will tend to have problems with. And then we need to remove the clutter from the room. And then keep in mind that L-DOPA with carbidopa is Cinemet, and if we can get them, consistent on their Cinemet, may help with the contrast sensitivity because that's going to increase dopamine uptake. Okay. Physical therapy, I didn't want to leave them out. Okay. Physical therapy, the OT students have learned proprioceptive neuromuscular facilitation, which means that I'm just really using lots of facilitation techniques to get that person to move in a big way. Okay? We're trying to get them to engage everything. The head leads movement. So we have to have head movement, we have to have eye movement, we have to have trunk movement, we have to have movement of the extremities. P&F is based on using quick stretch and firing the muscle. So if we can fire the muscle and have it radiate out into the whole extremity, has a bigger impact than just working on one finger. And that's why P&F is a good thing. I can, let's say if it's head and eye movement that I want to facilitate, I can look down at the floor, I can look over my shoulder, and then I can look up and around and on the other shoulder. So I'm combining lots of movement. Remember I said that clients with Parkinson's tend to have a forward head posture and it's down, by working on all of these things simultaneously, we should be able to get a better motor response and to prevent forward head and kyphosis. So that's what you're going for. And you'll see this in a moment when we talk about big. In stage 2, honing yard then, we're going to look at visual field, continues to look at saccade, continues to look at pursuit. This is when our clients start to have a shuffling gait and they start to freeze. And now there's all kinds of technology to prevent freezing. There's a client that comes to one of my classes and he uses a laser cane. Every time he freezes, he presses the button and the laser allows him to get started again. And that's what I refer to as bypassing the basal ganglia. If you have to think about it, that's a motor performance skill control by, remember I said remembering motor patterns? He's trying to engage the basal ganglia to remember how to get started again. But the light allows him to bypass it and get started again, and he doesn't have to wait to get started. Clients with Parkinson's disease say, "Are you kidding me? I'm not coming to Creighton and walking and try to get across the street from the cardiac center to the dental school. I'll just freeze in the middle of the street." So we have to think of alternative ways and how we can change and help them with their transportation. With stage 2, we're also going to be looking at, and I just highlighted a couple of these. Sure, we're going to do a balance test, but we're going to look at the functional reach test and the modified falls efficacy scale. The modified falls efficacy scale is tied to being able to reach for items in your environment. And they will report, you know what, from 0 to 140, some people may feel like they're a score of 10. I don't feel comfortable or safe reaching for anything in my environment because I may fall at this level. Okay. We talked about partial occlusion. We can use a patch or we can use a Fresnel patch, which is a little piece of plastic that does the same thing when it's put in the client's glasses. There's so many interventions now. We just have to work together to find the best one for the client. On this one is an intervention using prisms. And I'm going to stop here. We'll talk about it in a moment, and then I'll show you a little video on using prisms. And let me see. I think I got enough time to do that. Okay. Here's the thicker part of the lens. This person has a left vision field cut, and it's going to bring it right into midline so that they're able to see. So we're going to stop this for just a second. And see if we can get back here. So, nope, don't have it. Let's go 2 more slides, I think. Maybe we'll get it. Okay, let's just do 2 more slides here. Okay, and we'll look at base out and base in. Nope, it's here. I'm sorry. Stay with me here for a second. I'll get it. Let's look at this one. We talked about
a line problem. You might have an exo deviation. Exo is usually downwards, or an ESO deviation. That's inwards. There's also a hyper and a hypo, up and down. So let's give a couple examples of this. Let's say you have normal eyes, and one of the ways you can actually estimate if a young child has an eye that's turning in or turning out is by using the Hirschberg test. The idea is you shine a light at the eyes, and you look at the light reflex, the corneal reflex of that light bouncing off the eye, and you compare its position to the underlying pupil. And normally, that reflex ought to be laying right on top of that pupil. However, if you have one eye that's deviated, for example, this left eye is turned inwards, it's a left esotropia, then you can see that the light reflex is not quite over the pupil like it's supposed to be. In this case, the right hypertropia, the right eye is up a little bit, and you can actually estimate the amount of deviation. And the rule is for every millimeter that this light is off center, so in this case, if this was 1 millimeter off of the pupil, equals about 7 degrees of misalignment or 15 prism diopters, and this is the measurement that we actually use in clinic, prism diopters. So we'll go over prisms in a second, but the Hirschberg test Very useful. Now, we just talked about ESO, EXO, tropias, phorias. What does that mean? Well, tropia is when the eyes are always deviated. So again, exotropia, that means that the eyes are deviated out, they're wall-eyed, and they're always deviated. Now, phoria, on the other hand, just means that they're only deviated sometimes. So, example of a tropia would be exotropia or esotropia, and of course the hyper and hypo. And of course, of the phorias, we would call it something like an exophoria, an esophoria, etc., etc. So let's show an example of this. This eye looks like this left eye is deviated outwards, and we use our paddle to cover the eye. This is called the cover-uncover test. And you look for this eye movement, and that tells you that it's there all the time. So no eye movement here, because it looks like the right eye is the dominant eye. This is a left exotropia. So let's try to correct it. And to do that, we use prisms to try to get things back in alignment. Things are still moving, so this isn't quite enough prism to get things back in alignment. Let's try 20 diopters. And now we do our cover-uncover test. We can see that things are back in alignment. This was a left exotropia, approximately 20 degrees, 20 prism diopters, that is. And you pick tropias up with the cover-uncover test, which is what we just did. So let's try this one. These eyes look like they're in reasonably good alignment. So let's do our cover-uncover test. No movement. Things are still nice and stable. Let's try the other eye. Cover, uncover. Things are still in perfect alignment. Wonderful. But watch this. We'll do a cover, and we'll do a cross-cover test. Look at that eye move. Up, it's moving again. Up, that one's moving. This is what we call phoria. It's there some of the time, basically when we break fusion. And let's see if we can get rid of this phoria. Yep, about 10 diopters. A prism is all it took to fix this phoria. So this was an exophoria. There only some of the time, and there was about 10 prism diopters of it. And you pick up phorias with the cross-cover test, completely different than the cover-uncover test. Okay. So this is a loose prism, and certainly with kids, loose prisms are the way to go. They also make prism bars. Basically put a bunch of prisms in a single bar, and you just dial this thing up and down until you find the right amount of prism to correct. I personally hate these bars. I like to use the loose lens prisms. They're a lot easier to use. That's my own personal preference. Certainly with children, you want to use the loose lenses because they're smaller. If you use something this big, kid's going to try to grab it. It's not going to work well. And if you have a tropia that can be corrected by correcting with glasses or patching, then you can always go to surgery. And basically, when we have eyes out of alignment, we get them back in alignment. And we do that by either shortening or lengthening the rectus muscles. In this case, this rectus muscle is cut off from its insertion, and it's reinserted back onto the sclera using suture. And this basically lengthens the effective length of this muscle and gets things back in alignment. You can do the opposite. You can also shorten the muscle and reattach it back to its original insertion. And not an easy surgery to do, because you can imagine you're trying to do a scleral pass here and not perforate into the eye and hit the retina, and the sclera is very, very thin. I mean, so thin, we're talking about a third of a millimeter right underneath this muscle insertion. You can very easily perforate to the eye, and not an easy surgery. But
okay. Now that reinforces why we need prisms. Okay, and once the client gets the prisms, they are going to be referred to occupational therapy so that they learn how to use them for accessing or participating safely in occupation. Okay. Occupational therapists are beginning to address visual perceptual changes in Parkinson's disease. And Hanby talks a little bit about a model of getting clients with Parkinson's engaged in physical activity. Or I shouldn't just say physical activity, but being able to perform at different levels. It's the slowness of movement that impairs their motor performance, and it's not, they say it's not the rigidity, because they get the dopamine for the rigidity. So we need to look at how can we get them to engage their whole body in terms of moving. The more they move, the more we can engage or help to increase neuroplasticity. Karen Shepard says that we should change the task. We should have our clients performing activities in unexpected ways, because we ourselves don't carry our plate to the counter the same way every time. We don't get up from a soft cushion the same way every time. Clients with Parkinson's shouldn't be sitting on a soft cushion because they can't get up. So how can we help them be able to get up? Once we do exercise, and we know that exercise and dancing and doing everything in a big way is actually good for them. The earlier we can start it, the better. Schenkelman uses music, marching in place and using music, okay? But there are all kinds of ways to get them to engage. Some people cringe about having a client with Parkinson's disease, so some of these clients have strokes, but we could do the same thing with Parkinson's, of having them reach down to the floor so that they can feel what it's like to change their posture from being upright all the time or leaning over, okay? Of course, with assistance. Lee Silverman's voice treatment, LSVT Big, you know, you pair the exercise with big words and big sounds, is a wonderful thing. And I thought this was interesting. Eye movement was not directly addressed in Lee Silverman, but it's easy to incorporate. This lady with the ball over her head, by having her look up and then down when she throws the ball, will actively activate the vision system and the head. So we can build it into the home exercise program. For stage 2 Parkinson's disease, yoga, Tai Chi, all of these things are great for helping to reduce falls and to reorganize the system. And most clients with Parkinson's really enjoy doing those, okay? Big universal ball exercises. And I'm only going to talk about we for a second. One of my post-professional students and I just did a research project, and we did a qualitative study looking at using the we and whether or not the we could actually be used for a graded home exercise program and changing motor performance and changing level of depression. And so now we're in the throes of completing data analysis and trying to get it published. So it was really an interesting study. The we, remember I said bypassing the basal ganglion? The we does that very well because you don't have to think about the movement. You're using your vision to drive your movement, and you're not saying, it's like, I have to hit the tennis ball. It's automatic, and we want the clients to get to the point that it's automatic. In our research, we looked at playing softball, bowling, and playing tennis. Those were the 3 sports that we selected, and we looked at their pre-scores and their post-scores and whether or not they improved and how their fitness score improved with doing the weight. And we had some significant results. So it's amazing how something that simple can actually not only change posture, but change head position, change kyphosis, change proprioception by doing the weight. And the thing is, you have to be consistent. Our challenge now is someone grant-wise willing to help us buy enough Wii's for the Parkinson's disease support group so that we can have a larger study. So, and we're working with a neurologist over at the Med Center, Dr. Bertroni. Some of you probably know him. He was involved in the study. Okay. On stage 3, Hone and Yard, it's the visual stabilization. Remember I talked about the clients have poor contrast sensitivity, but because their eyes are not working together well, and it goes back to the striated muscles, they tend to not be able to hold an image on the retina for a long time. And if you can't hold the image on the retina and it's constantly slipping, you don't know if you're going or coming. You know, that's a strange, that's a strange feeling to have in your system if you can't hold eye gaze on an object and follow it through. So that creates safety issues as well for clients with Parkinson's. You can see that this gentleman, his balance is being tested. And his head, and you'll watch it in the video, I'll play the video for you, but his head never moves, but his body keeps moving, you know, and so he can't correct his posture. His head stays in the same position. And I'm like, well, if his head stays in the same position, his eyes must be in the same position, because we can look and go, oh, I'm going to turn and grab something to help me. They don't do that, okay? So what does that mean? All right? Under stage 3, we're still going to look at the timed up and go now. We're going to look at the Humphreys, the Vibava, and we're starting to look at reaction time. It's so important to look at their reaction time. In most OT clinics, and I'll say rehab clinics, Emmanuel and Madonna in particular, have the Dynavision. And so we can use that eye-hand coordination to see how fast they're responding to light. That might give us an indication of how fast they're responding to items in their environment as well. We can have them do it from a seated position, from a standing position, from a side position, and we can get all the vision fields in there. Okay? I put this in here just to get people thinking about, it's boring to sit there and look at a pencil and follow it with your eyes. They want to be engaged, and that's why the Wii or playing a game is so much better than just watching a pencil. But these are some exercise cards that some clients get sent home with. The one thing that I do like about this is that we can pair balance with looking at a specific point, and we can challenge them to get their head position up. Okay. This is stage 4 of Hone and Yard. Okay. They have lots of problems with perceiving a vertical position. The globus pallidus and the substantia nigra help us to perceive when we're upright, and this client is just gradually going downhill, poor balance. And then all the way to stage 5. It bothers me if we do nothing and our clients end up in this position or this position or end up in a chair, a power chair, not a power chair, but a tilt-in-space chair, and they're fed through another alternative means when some of this could have been prevented. I want to stop here and show you the video so that you'll have a full appreciation for, and this will be about 4 to 6 minutes.
Hone and Yard described a useful clinical staging system for Parkinson's disease. This man has unilateral disease, which is Hone and Yard stage 1. His resting tremor is present only on the right side, and the right face is slightly masked. Although this man has mild unilateral symptoms, those patients with very severe symptoms limited to one side are also classified as stage 1. This man walks briskly and without hesitation. His posture is erect. However, he doesn't swing his right arm while he walks, but instead holds it flexed at his side. That is, his unconscious or associated movements are impaired. This man has stage 2 Parkinson's disease, which is defined as bilateral involvement. When he walks, his arms are flexed and associated arm movements are decreased on both sides of his body. Tremor is present bilaterally. His posture is stooped and his steps are shuffling and slightly shortened. In stage 2, postural reflexes are normal. Hone and Yar stage 3 includes patients with postural reflex impairment and mild to moderate disability. Like the first man, this man has stage 3 disease severity. His posture is stooped, and he has a shuffling gait. His associated arm movements are decreased. When he turns, he takes many small steps.
His head did not turn.
He also has bilateral resting tremor. This patient demonstrates all the signs required for Hoehn-Yahr stage 3, that is, bilateral disease with postural reflex impairment. After a postural threat, he is unable to stand still and takes several steps backwards.
This patient has stage 4 Parkinson's disease. He has recently fallen, which is one of the problems when significant postural reflex embarrassment occurs. Stage 4 Parkinson's disease means that the patient has severe disability, bilateral signs, and poor postural reflexes. He, however, can get up out of a chair with effort, although he may not succeed on the first attempt. He can walk independently, although his gait is abnormal. A slight push causes him to fall, and even the threat of a push can, in fact, cause him to lose his balance.
And one point about shoes, no crushed rubber sole, usually leather sole, and then they need to be tie-ups or lace-ups or Velcro closures, no slippers. That's setting him up for his fall.
In stage 5 Parkinson's disease, the patient is effectively chair or bed bound. The patient cannot get up from a chair without total assistance and cannot stand without constant attention from the family or physician. The feet are usually glued to the floor, and as the patient falls, there's no recuperation, and the patient will fall en bloc.
No appropriate push.
However, even in patients with severe Parkinson's disease like stage 5, certain visual cues like the lines on the floor can change function transiently, as in this demonstration.
And I call that bypassing the basal ganglia because she's getting that visual cue. This is what I'm supposed to do. This is what's laid down in my motor system, my memory. But if you say pick up your foot and step, she can't do it because that's verbal and it's calling from a different part of the brain. Okay. Okay, that was the last slide. Questions? It was a lot of information. That's why I gave you a handout. I knew it was going to be a lot. And that was even with taking out all the neuro stuff.
Are some of these things corrected with things like the L-DOPA? If they increase dopamine, does anything...
What we know, and just having worked with Dr. Petroni over at the Med Center, it takes everybody being on the same page. You need to take your medication, but you need to be working with OT and PT and getting on a good exercise regime. Our goal is to keep your head up and prevent the kyphosis. Because once you get into stage 3 and 4 and you're here or your balance is off, that's why we're advocating for exercise, 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 and more exercise. At UNO, Dr. David Corbin's wife, I can't think of her, Meadow Corbin, does the dance program for clients with Parkinson's disease. So she teaches them to dance, and they show up to dance.
Yeah, well, I was going to say you would have to make some of that fun.
Yeah, it has to be fun because exercise is tedious and can be boring. And for our study, we had clients driving from Lincoln, and one person dropped out because of the drive. It was just too fatiguing to participate in the study, then turn around and drive back to Lincoln. Yeah. Yes.
Do the eye movement exercises have any impact on the contact? Or is there any?
Totally separate. Two separate things. One is the eye movement, the other is contrast sensitivity. And we need to, as OTs, we need to assess that multiple times and ongoing because it may start to get worse, and then we need to have an intervention in place for that. And work with physical therapy. Physical therapy can do the exercises, but we're like, please don't ignore the head. You've got to get the head in there. Okay, the body follows the head. Yes, ma'am.
So what is your relationship with the neurologist? How do you work together with them?
What is my sometimes I think Dr. Petroni thinks I'm out there somewhere. but over the last, when he was here at Creighton and I needed clients to come to class, I would always call him and he'd say, you can have this person, this person, this person. And so one of the students wanted to do his professional rotation. And he said, I want to work with clients with Parkinson's. And I said, well, what do you want to do? And he said, will you brainstorm with me? And I said, absolutely. So we brainstormed. I said, what you're outlining to me is Dr. Petroni, and I know that he's and Dr. Body. Dr. Body is his neuro fellow over at the Med Center. I said, this is what you're telling me. So we presented our program on the telephone. We did a phone call to him. And I said, this is Shirley? And he said, what do you want? Because I always want something. And he said, and I said, this is what we propose to do. We'll write up the study, but we want you to do the Parkinson's disease rating scale, pre, post, and follow-up thing for us. And he said, absolutely. So he was on board. He gave us access to his patients, you know, and we used his patients for the study. And we're like frantically, it's going to get submitted. We're getting it edited now and chopped down. You know, we're OTs, we're real flowery, we make everything pretty. In scientific writing, you got to get rid of the flowers. You know what I'm saying? So we've gone from probably 8,000 words down to 4,000 words, which is within journal range. And we worked on that late this week, and so it's going to go to him for a final review, and he'll put his section in. So I'm excited about it, and I'm excited about what we could possibly do. What's my relationship with him? He answers all my questions. I wish he would ask me more questions sometimes, but that's just time. I think it's just his time because he has so many patients. What you might not know is in the state of Nebraska has one of the highest populations of clients with Parkinson's disease. We have 13,588 people with Parkinson's disease. In the state, they did like a screening, and they thought it was like 30,000, but about 15 of those were misdiagnosed. It was something else. They had some features that looked like Parkinson's, but it's something else. So I'm like, so what if we can get people to not go from a 2 to a stage 5 just by doing or consistent exercise and walking and working with their neurologist and working with their speech pathologist and working with their physical therapy, and every therapist and everybody's on the same page. It would be totally exciting for me. Did I answer your question?
Yes.
Yeah, I can get.
Thank you.
Yeah. Other questions? And I always say somebody, most people in here know somebody with Parkinson's, you know, and if I could just show them this, and that's what we're trying to do. We made a video of this same information and broke it down for health literacy purposes so that they can take it to their support group all over the state of Nebraska. They show the video. And last week, the speech pathologist that actually runs that program over at the Med Center, Karen Anderson, called me and said, would you give us permission to use this so that we don't get in trouble with copyright? So I had to write out a letter about, I had to write out a legal letter about how they couldn't sell it, but they could use it for all of their meetings, and they can't mass produce it, and they have to check it out and check it in. I can't believe how much stuff you have to do just to get stuff to people to be able to use. But anyway, we got it worked out so that they can use it for their support groups. And they actively go to the ophthalmologist and the optometrist, trying to get them to go at least 1 or 2 times a year and let us know what the results are so that we can plan around that. Thank you for coming. Thank you. Thank you. Right.